Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the study by Payne and colleagues entitled Phase 2 Pilot Study of Intravenous High-Dose Interferon with or without maintenance treatment in melanoma at high risk of recurrence. My name is John M. Kirkwood, and I am Professor of Medicine, Dermatology, and Translational Science at the University of Pittsburgh Cancer Institute in Pittsburgh, Pennsylvania. My oncologic specialty is melanoma. No new treatment has emerged from more than 20 investigations since the FDA and worldwide regulatory approval of postoperative high-dose interferon therapy of resected stage 2B and 3AB melanoma in 1996. Trials have tested various interferons administered at a range of dosages, routes, and schedules for intervals ranging from 1 to 60 months and demonstrate that interferon has consistent and now uncontested benefits in terms of relapse prevention, with up to 33% reduction in the hazard of relapse with high-dose interferon and 17 to 18% reduction in the hazard of relapse in the most recent meta-analyses of the aggregate data. However, the impact of interferon upon mortality has been less consistent in individual trials reported since 1996 and in meta-analyses of the data from 14 to 17 trials, where significant improvement across all trials was 9%. The question of optimal dosage, duration, and schedule of therapy has been impossible to resolve through meta-analyses, and the most recent Cochrane analysis reported in 2013 suggests that further data upon dosage and duration is needed. The individual trials conducted to date demonstrate a significant impact of high-dose interferon upon overall survival in E1684, the pivotal trial that enrolled predominantly recurrent or bulky stage 3B disease patients. And the hazard of mortality was reduced 28% in this trial with 1 year of high-dose interferon. However, despite a significant reduction in the relapse hazard in the sequel trial 1690, there was no evidence of improved overall survival in this trial that was conducted half before and half after regulatory approval of high-dose interferon in 1996. The observation of relapse reduction without an impact upon survival in E1690 has been attributed to the regular adoption of high-dose interferon salvage therapy in nearly all patients who were initially assigned to observation and then relapsed in regional lymph nodes during that trial. The largest published U.S. intergroup trial, E1694, was designed to test the ganglioside vaccine GMK in relation to high-dose interferon as the reference standard, and showed a 30 to 33% reduction in the risk of both relapse and mortality for recipients of interferon compared to those who received the GMK vaccine. These results were previously questioned by some who were concerned that the GMK vaccine might have adversely affected relapse and survival among GMK vaccine recipients. However, the recent publication of mature results of the EORTC 18961 trial comparing GMK vaccine versus observation reveals no significant impact of GMK upon either relapse-free or overall survival. These final results of EORTC 18061 allow a much simpler interpretation of the E1694 trial, where interferon achieved a 33% reduction in both mortality and relapse compared to GMK, which now can be comfortably interpreted as a placebo. The E1694 trial can therefore now be included in the evidence that supports high-dose interferon impact upon survival of high-risk operable melanoma. The landscape of melanoma for advanced disease has evolved considerably in the past several years with the approval of BRAF inhibitors vemurafenib, dabrafenib, and the MEK inhibitor trametinib, as well as the anti-CTLA-4 blocking antibody ipilimumab for therapy of metastatic melanoma. The role of IPI, tested in two large cooperative group trials, EORTC 18071 and E1609, have not yet reached their conclusions, and two trial interventions directed at MAP kinase pathway aberrations are all earlier in accrual and pending. Trials of the anti-CTLA-4 blocking antibodies and the BRAF-MEK inhibitors should yield important new information within several years. Given the lack of mature evidence to support alternative new approaches that will anytime soon change the landscape for adjuvant therapy of melanoma, efforts to understand the avenues to improve our effects with interferon alpha-2b have increased in priority. The role of interferon alpha as a modulator of the tumor microenvironment and a key factor in the host immune response to melanoma has continued to increase, and the interest in the type 1 interferons has grown since approval of interferon alpha-2b in 1996 for adjuvant therapy of high-risk melanoma. Analyses of interferon administered at a variety of dosages, schedules, and routes, as well as different durations, have left more questions than answers, as noted above. And the key issue that has emerged from the experience with lower dosage regimens of recombinant interferon alpha and newer formulations of pegylated interferon alpha relate to the therapeutic index in the various disease stage groupings. Our initial hypothesis regarding interferon as immunotherapy was that this agent should have its greatest effect in early disease. In E1684, E1690, and E1694, sentinel node evaluation was performed in a minority of patients, and patients presenting with stage 3B macroscopic nodal disease or with recurrence comprised a majority of subjects in the E1684 and a significant fraction of the subsequent trials as noted. Studies of the French, Austrian, and German multicenter groups addressed lower dosage regimens and enrolled patients with lower disease burden. The EORTC 18991 trial of PEG interferon was the first to systematically pursue sentinel node staging and showed evidence that anti-tumor effects of this regimen that were predominantly manifest among microscopic N1 disease populations with a hazard ratio of 0.82, confidence interval of 0.61 to 1.1. The p-value for this difference, 0.08 in terms of relapse reduction, was not significant. There was no similar evidence of activity of pegylated interferon among macroscopic N2 disease populations, and no significant effect upon survival in the overall trial or any subgroup of the trial at final analysis in 2012. What is the role of disease stage group, tumor burden, and risk profile? The Payne study that accompanies this podcast is particularly important since it addresses a population at higher risk with stage 3B and C disease that resembles the largest subpopulations enrolled in the pivotal study E1684 and the largest published U.S. intergroup trial E1694. This higher risk population has been targeted in the current U.S. intergroup trial E1609 testing ipilimumab at 10 or 3 milligrams per kilogram versus high-dose interferon. Since the pivotal trial E1684, no trial of high-dose interferon has enrolled a population at the very high-risk category addressed in the Payne study, although this group is likely to be the most rapidly informative due to its high relapse risk and mortality rate. The populations addressed by adjuvant interferon trials in the U.S. have diminished in risk progressively over time. Only the E4697 study of GM-CSF and peptide vaccination and the S0008 trial of biochemotherapy have addressed higher risk stage 3B groups and those with resectable stage 4 disease. And neither of these studies that have only to date appeared in abstract form showed a significant impact upon overall survival. Whether interferon or other candidate adjuvant approaches have benefits that differ according to the stage or burden of disease in these trials has been an important question, and at least for high-dose interferon, the evidence in E1684 and E1694 has not demonstrated a differential benefit from the lowest to the highest risk subgroups. The RFS hazard ratio for the N0 group was 0.46. The RFS hazard rate for the N3 and more than 4-node group was 0.53 in the latter of these studies. The null hypothesis has then been that the benefits of therapy are homogeneous with high-dose interferon across the risk groups, and that the event rates which define information time do not relate to differential effects of therapy. This concept may require some revision for new checkpoint inhibitor immunotherapies that recall or reverse tolerance amongst T cells, since the benefits of checkpoint inhibitors may depend upon tumor antigen-exposed T cells so that patients with lesser disease burden may be less susceptible. The power of our trials to detect an impact upon mortality will always benefit from enrollment of populations with higher event rates, assuming the magnitude of treatment impact upon relapse and mortality is homogeneous across the operable disease stages. It is notable that the E1694 trial, like the E1684 pivotal trial, enrolled a significant fraction of patients with multiple nodes involved, a third with 2 to 3 and 4 nodes positive in this latter trial, with 45% of nodal disease involvement macroscopic and 36% of patients treated at gross disease recurrence. What is the role of high-dose interferon treatment duration? This question has been among the most pressing for physicians and patients alike. The optimal duration of therapy has been uncertain, and with regulatory approval for high-dose interferon administered for 1 year and for pegylated interferon administered for 5 years, patients are faced with a dilemma. The E1684 regimen tested 1 year of treatment for purely pragmatic reasons of patient acceptance. Given the inclusion of IV induction and subcutaneous maintenance components of therapy, one issue has been whether 1 month of IV induction alone might be both necessary and sufficient for the benefits of this therapy. Payne et al. Have asked this question quite differently from 2 prior studies. Pescasides et al. Conducted the Hellenic Oncology Group trial 13A98 to test the role of duration of interferon alpha-2b treatment, but used a modified 25% dose-reduced regimen of high-dose interferon in the first month and a maintenance regimen which was not 10 million units per meter squared thrice weekly, but 10 million units thrice weekly at a flat dosage for a reduction of perhaps 40% in dosage there. They showed no difference between these 2 arms, but had no observation control to assess the impact of this dose-modified regimen, if there was an impact. And the size of this trial, together with its inclusion of a minority of patients with stage 3B and C, qualifies its ability to demonstrate meaningful differences between the 1-month and 1-year treatments. The trial was not designed to detect differences smaller than 15%, which is close to the magnitude of the treatment benefit in meta-analyses already described from interferon trials all told. The U.S. intergroup trial E1697 asked the question regarding the benefits of 1 month of therapy by focusing upon stage 2A and 2B disease. Patients who would not have been candidates for 1 year of high-dose interferon therapy and tested a 1-month regimen of high-dose interferon induction versus observation. This trial was aborted in 2011 for futility after enrollment of 1,150 patients and has been presented to date only an abstract at ASCO. Payne et al. Have tested a full high-dose interferon regimen as it was originally articulated in E1684, comparing it to a 1-month IV induction phase, enrolling higher-risk patients, among whom 80% had stage 3B or C disease. Despite the limited number of patients enrolled in this study, marginally significant differences were noted between the full year of high-dose interferon and the 1-month IV induction abbreviated arm of therapy in relation to overall survival. The implications for the field are significant, given that smaller benefits upon relapse-free survival, a hazard ratio of 0.87, were reported for 5 years of pegylated interferon as tested in EORTC 18991 without any impact upon overall survival. and the futility of the 1-month IV induction regimen that was tested in lower-risk Stage 2AB patients and Stage 3A patients enrolled in E1697. There is therefore no support for the use of 1 month of interferon therapy alone for either lower-risk or higher-risk patients with resectable melanoma, and increasing support for the pursuit of conventional maintenance dosing thrice weekly with recombinant interferon at 10 million units per meter squared thrice weekly for a year in patients with Stage 3B and C resectable melanoma. This is the subgroup of EORTC 18991 patients for which there was no hint of activity with pegylated interferon. The results of the trials now in progress testing immune checkpoint inhibitors, anti-CTLA-4 blocking antibody ipilimumab in E1609 and EORTC 18071, as well as the new molecular inhibitors of the MAP kinase pathway in BRAF V600E mutant disease, are awaited to augment the current landscape of adjuvant therapy. The choice of overall survival as a primary endpoint of the intergroup trial E1609 appears to have been apt, given the enrollment of patients with stages 3B and 4 M1AB resectable disease, where improved survival is critical as a goal. These deliberations are also apt in relation to future planned adjuvant trials of the anti-PD-1 antibodies and PD-L1 modalities that have emerged over the past year, where improved survival may be sought as well. Thank you.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.